Patients that have abdominal aortic aneurysms are monitored for symptoms and also for growth of aneurysms. The reason we do this is because of the risk of rupture and death from rupture. Once an aneurysm is identified and it is found to be over 5 centimeters in a woman or 5.5 centimeters in a man, then they are offered repair of their aneurysm. There are 2 different ways that you can repair an aneurysm. For many years, we did an open abdominal repair where you had a large incision and you would spend over a week in the hospital, and it would take 6 weeks to recover from the open operation. In 1991, we started to perform EVARs in this country. EVARs stands for endovascular aneurysm repair. So there are patients that are seen in the clinic for surveillance of aortic aneurysms, and they will frequently have an abdominal ultrasound to evaluate the size of their aneurysm. When we are considering an operative repair, then we would get a CT scan to look at the aneurysm in more detail, and then that will give us a blueprint of how to repair the aneurysm. There are patients that will come in through the emergency department that are symptomatic with abdominal pain or back pain, and in that case, if they come through the emergency department, we would obtain a CT scan to help us plan their operation, and some patients are taken directly from the emergency department or even from the helicopter directly to the operating room for an emergency repair. Some patients do not have any symptoms at all, and it can be picked up on a screening ultrasound for the initial Medicare history and physical. An ultrasound can be obtained, and then the patient can be screened for it. And the patients that need screening are patients possibly a family member had an aneurysm, or patients that are more at risk that are smokers or with high blood pressure. So some patients will come in with symptoms such as blue toes. The aneurysm may throw blood clots to the toes. Other patients may come in with abdominal pain or back pain because of the aneurysm is growing or getting ready to rupture. If the aneurysm ruptures when a patient is not in the hospital, the mortality is as high as 80%. So if the patient makes it to the hospital and the aneurysm is ruptured, if we offer repair, 50% of those patients will get out of the hospital alive. So many patients do die from a ruptured aneurysm, so ideally we fix it on an elective basis before it is ruptured. The day of the operation, the patient arrives into the pre-op area, and the patient will be evaluated by the surgeon and also evaluated by a nurse and evaluated by an anesthesiologist. Then the patient is taken into the operating room, and the patient will be put to sleep, and they will be asleep during the operation. The majority of the time, the patient is asleep under a general anesthetic. At times, we do these also under local, where we numb up the groins and the patient is not asleep. That is dependent upon the patient's condition. Once we're in the operating room and anesthesia has the patient comfortable, we will make sure that both of the groins are clean and make sure that there is no evidence of infection, and then we will prep out the groins and get everything ready for the operation. Everything is done under a sterile environment, and then we will use an ultrasound to look at the groins, look at the blood vessel, and then we essentially put a large IV into each of the groins, and it's through this large IV that the graft will be delivered. There are many different grafts that are available on the market, and the doctor will look at the aneurysm and pick a graft that will best fit that patient's anatomy. And once a graft has been selected according to the size of the aneurysm, that graft will be introduced through the blood vessels in the groin called the femoral artery. And through the femoral artery, the graft is advanced into the abdominal area into the aorta. And this is all done under X-ray so we can see where everything is going. And then we take pictures called an angiogram where we shoot dye through the blood vessels. We mark where the aneurysm is present, and then the graft will be opened up by pulling a wire or by unsheathing the graft, and it will open up underneath the renal arteries. We then introduce a balloon to balloon the graft open so that it will stay in place. So the majority of these aneurysms are below the renal arteries, or it's called an infrarenal abdominal aortic aneurysm. After the operation is complete and we do an angiogram and we make sure that the graft is in a good position, we make sure that there's not blood flow into the aneurysm any longer, we take everything out of the groin and we make sure that there's no bleeding from the groin. And we make sure that there's good blood flow to the legs. Once the operation is complete, the patient will wake up from anesthesia in the operating room, and then the patient will be taken to the recovery room. The family is then notified of the outcomes of the operation. The patient is greeted in the recovery area by a nurse, and the nurse will continue to monitor the patient as they wake up from anesthesia and will continue to check the circulation to the legs to make sure that there is still good blood flow to both of the feet. After the patient leaves the recovery room, they will be admitted to the hospital overnight for 24 hours. They're monitored for things such as bleeding, fever, upset stomach, nausea, vomiting, and the majority of patients go home the next day. When a patient is at home, they're encouraged not to do any heavy lifting for the first week. They still have some incisions that are healing in the groin, and then they will have a follow-up in the clinic to check their groin incisions. After they are seen in the clinic to make sure their groin does not have any infection, they will also have either an ultrasound or a CT scan to make sure that their aneurysm has been repaired and that the stent graft is in a good position. Once the procedure is done, the patient will continue to follow up in the vascular surgery office for the rest of their life. We continue to monitor the graft to make sure the graft stays in a good position and make sure that the patient doesn't develop an aneurysm above or below where the graft is placed. So once the patient has had the aneurysm repaired and we make sure that there is no complications in the groin and we make sure that the graft is in a good place, patients can return to their normal. They will go back to their normal activity. Of course, we say if they're taking any pain medicine, they can't drive, but frequently patients don't even need pain medicine. They can take something over the counter for the groin discomfort. We realize that having an aneurysm is very scary for a patient. Most patients identify with aneurysm and know of it as death. They're afraid it's going to rupture. This is something that we deal with on a routine basis. So we encourage patients to come, be evaluated, because we want to help patients to have it fixed before it becomes a problem. So our doors are open, whether it's a straightforward aneurysm, or if it's something complex, or even if it's just family member has an aneurysm and you want to be screened and evaluated for it. Our doors are open to help patients in whatever way they would need.